Okay, everyone. Hello again. Thank you so much for joining us tonight for our webinar, Regaining Your Masculinity After Bladder Cancer. As I said, my name is Alex Wong. I'm a longtime BCC volunteer, lead of the Hamilton Support Group, and moderator of the online discussion forum for those of you who've been there. And I'm honored to be facilitating this session tonight. I'm so happy all of you could be here tonight to learn about strategies to address some of the sexual side effects that can come with bladder cancer treatments. At Bladder Cancer Canada, we believe that education empowers patients and can help facilitate an increased quality of life for people affected by bladder cancer. And that is what tonight is all about. Please remember that webinars contain content intended for the sole purpose of information sharing and should not be considered medical advice. Always talk to your doctor or your urologist about what is best for you. And now I am honored to introduce our presenter for the night, Dr. J. Nayak. Dr. Nayak is a urologic oncologist, hopefully I pronounced that correctly, associate professor at the University of Manitoba, and co-founder of the Men's Health Clinic Manitoba. We are truly grateful he is here to cover this sensitive topic for all of you tonight. Thank you so much for being here. I will pass it over to you, Dr. Nayak.
Thank you very much for the introduction. Thank you to Bladder Cancer Canada for having me here today to talk about this important topic. And it's a pleasure to be here because I think that when we talk about masculinity, we talk about sexual function after bladder cancer, it's a topic that isn't talked about on a regular basis. So I think that hopefully we'll be able to talk about some of the things that maybe you want to talk about and you want to bring it to your doctor's attention, but maybe not had the opportunity. And we'll just kind of take a review of just what sexual function looks like as it pertains to bladder cancer. So in terms of a little bit of an outline, I was hoping to cover the male anatomy and physiology, talk about sexual function and dysfunction. I think probably one of the most important things, though, will be to discuss barriers to care. Why do some patients continue to have erectile dysfunction? And what are the barriers that they are faced with when trying to seek help for this particular issue? We'll talk about some of the causes of sexual dysfunction, both in terms of general causes and then a little bit more specifically as it pertains to bladder cancer. And then hopefully we'll have some time to review the management of erectile dysfunction and just sort of give you the 30,000-foot view on what sexual function and erectile dysfunction management could look like. I do apologize if you hear vacuuming in the background. I'm late at the clinic, so the cleaning staff is well underway. So if it's an issue, please let me know. So I did want to start with a little bit of a disclaimer. We intentionally chose a little bit of a provocative title for the talk. And by no means does having erectile function make somebody more masculine than another. But I think as men, it's common for us to link the two together. So I don't want to offend anybody to suggest that you're any less masculine if you don't have this sort of function, but it is something that we want to talk about a little bit more. So without further ado, we'll talk a little bit about the anatomy and the physiology. So many of you may be familiar with this, but I do want to spend a little bit of time just highlighting the anatomy. I've had so many patients, even patients who've been years into a diagnosis of bladder cancer, and they still are not sure kind of where the prostate is, and we kind of go through it. And that's why I really want to make sure that we're not going to assume anything. We're just going to keep it really straightforward and highlight some of the fundamental anatomy and physiology aspects of men's health. So just looking at the picture here, hopefully you can see my cursor. We have the urinary bladder, and the urethra runs through the prostate, out the penis, and out the urethra. So if you look here at the prostate, this is a pretty important organ in that it's also part of the sexual organs. So the testicles, which make the sperm and the seminal fluid from the seminal vesicles, those all plug in through the ejaculatory duct at the level of the prostate. So anytime somebody's had prostate surgery, there can be issues with ejaculation changes or even erectile dysfunction, depending on a few factors. But this is kind of how they all tie into one another. In a radical cystoprostatectomy, which would sort of be the standard surgical approach for invasive bladder cancer that involves removal of the bladder and the prostate as well. And some people say, why? Why do you have to take the prostate? Why not just leave the prostate behind? And that has been studied as well. But it turns out up to 40% of men who have bladder cancer who undergo radical cystoprostatectomy will be found to have prostate cancer as well. So, it's not something that we normally like to leave behind if we can avoid it. Looking at that a little bit closer, and this is where I think erectile dysfunction is so common after major pelvic surgery, is that the pelvic nerves lie along the inner pelvis, and there's different nerves. There's the pudendal nerve, and there's a pelvic plexus of nerves. But I always like to tell patients too, when we do nerve sparing for different indications, it's not like I can take my phone and move my phone to the other side and say, okay, I spared the nerve. I moved the nerve out of the way. Nerves just unfortunately aren't like that in the pelvis. These nerves are mixed amongst the tissue, and it's not something that you can always see. So when we're doing pretty big surgeries like bladder removal, inherently we're doing that type of magnitude of surgery because the cancer is more serious. And we want to make sure that we're doing a good job at surgery and going wide enough that we don't leave anything behind. So you kind of have to go through tissues to remove the bladder, but in those tissues invariably is some element of some nerves. And I mention that because it's not just people who have bladder cancer who have issues with erectile dysfunction. Any type of major pelvic surgery, like radical prostatectomy, is one of the most studied pelvic surgeries that we do, but is also well studied in terms of its relationship to sexual dysfunction. But even colorectal cancer, patients who have rectal cancer and big pelvic resections of the rectum, which is just deep to the bladder and the prostate, like they can get this issue too. So it's very, very common. Zooming in a little bit closer on now on the penis. So the penis has a lot of vascularity. It has nerve supply to result in sensation and orgasmic function, etc. But then there's also nerve involvement in terms of helping to dilate the vessels and knowing when to dilate the vessels to allow blood flow to come in to result in the erection. This diagram, what it basically sort of highlights is that at the top of the penis, so if you were kind of looking down at your own penis, this would be the top, like the 12 o'clock position. And that's kind of the busy area of the penis. So you've got your bigger nerves, your bigger blood vessels in that location. That becomes a little bit more important if you ever were to undergo treatments for erectile dysfunction, such as intracavernosal injections, which we'll get to. And with that type of therapy, it's important to be injecting on the sides of the penis just to make sure you don't hit this important structure. Zooming in even further, this is a cross-section of the penis. So I like to say there's three major structures to the penis. There are two corpus cavernosum, also known as the corporal bodies. And then we have the corpus spongiosum. So this is where the urethra is. This is where you would urinate from. But it's this corpus cavernosum that has an artery within it. And almost view this cavernosal tissue as like a web of sort of vascular tissue. So when you get an erection, it's these two corporal bodies that engorge with blood and get rigid and result in the erection. Just understanding this anatomy is also helpful because down the road, one of if everything else has failed and you still want to have erections, one of the treatments could be the placement of an inflatable penile prosthesis. And I'll have some pictures about that later. But those prosthetics basically serve to replace this tissue in the corporal body so that you have two cylinders to keep the penis rigid, just like it naturally would be in pre-surgery, for example. With respect to the basic physiology of an erection, it's actually fairly complicated, and it also involves a lot of different systems. So in general, there's an element of smooth muscle relaxation. With smooth muscle relaxation, you get dilation of the artery, the cavernosal artery. That will allow that corporal body, the corpora cavernosum, to fill up with blood. When it fills up with blood and it stretches and stretches, you end up getting compression along the outsides here of this venous plexus, which veins normally drain the blood away, and now that blood can't drain away. So blood's going in, can't drain out. Pressure builds up, you get an erection. So that's kind of normally how things would work. And then the detumescence, or the loss of erection, basically is sort of the reverse of that happening. In terms of sexual function and dysfunction, I think it's really important to just emphasize that sexual function is very multifactorial. It does not mean exclusively erectile function. Like, under this umbrella, we would consider sexual desire, orgasmic function, ejaculatory function, even penile length, body image, how you feel about yourself emotionally, psychologically, how your relationships are, and even sometimes social concerns and stigma can factor into an individual's sexual function. Sexual dysfunction, on the other hand, is also multifactorial, but just from a different perspective. So this is generally how we break it down. So organic causes of sexual dysfunction would be things like, you have a history of high blood pressure or diabetes, or maybe some medications you're on have the side effect of erectile dysfunction. Like, all that would sort of fall under the organic category. Iatrogenic, I think that's iatrogenic means basically caused by someone else. So if you've had surgery and you went into surgery with erections and you left surgery without erections, that would be an iatrogenic cause of the dysfunction, because surgery happened and then now you have the erectile dysfunction. Psychological, huge emphasis on psychological reasons. We're going to get to that later, but stress, relationships, all of that is very important, and that ties into partner-centered causes. Whether it's having a healthy relationship, or maybe not even being in a relationship, that can also result in dysfunction. And sometimes also life changes. Not everyone stays 18 forever, right? So we all age, we all have our own challenges. And sometimes over the course of life, whether it's because you want to or not, sometimes priorities change, and maybe sexuality is not kind of the be all and end all and the main priority in your life or in your relationship. And that's okay too. I do want to assure you and reassure you that you're definitely not alone. Erectile dysfunction is very, very common, particularly after bladder or prostate removal, but it can also happen after TURBTs, radiation, or even just being diagnosed with cancer. But in some of the studies out there, 80 to 90% of patients are going to have fairly significant erectile dysfunction after surgery. And this could be related to a lot of different reasons. It's been postulated, kind of go through those later. But at the same time, it's important to remember that while surgery can take the blame for a lot of these cases, as men get older, erectile dysfunction naturally becomes more common too. There's been a few longitudinal studies that have estimated about 70% of 70-year-olds are going to have some erectile dysfunction. And erectile dysfunction can start to kick in as early as age 40, depending on a variety of factors. And that's not even accounting for things like hypertension, diabetes, cardiovascular disease. If you have those, greater than half of people are going to have some element of erectile dysfunction. In fact, early onset erectile dysfunction sometimes could be an indicator of underlying cardiovascular disease. So we sort of have two issues here. You've got bladder cancer that can cause erectile dysfunction, but bladder cancer in general is going to be diagnosed a little bit later in life in a population who already is at risk of erectile dysfunction. So one important thing I think also to review is like, what are some barriers to care? I think that it's divided into a few different topics here, but psychosocial barriers is definitely something worth talking about, because for men, having firm erections, ejaculating, being able to pleasure their partner, it's sort of central to being a man and having this masculine identity. And there have been studies that have shown that once somebody loses their erections, they start to feel emasculated. And men being men, sometimes they stop trying. If they grieve the loss of their sexual function, they feel like they've lost some masculinity, and then they may try erectile aids like Viagra, Cialis, these sorts of things. But maybe if it doesn't work once, they're not likely to try again. And there's some studies that say 73% of men sort of give up after failing one erectile aid. There have also been studies that have shown that in patients who have kind of close relationships with a partner, going into surgery, after surgery, that those men generally are, maybe it's encouraged by their partners to try more things, and sometimes that can result in ultimately success if you sort of don't give up and you keep trying until you find something that works. But inherently, sexual activity is a very private matter, and that likely reduces help-seeking behaviors. So I think that for men to ask for help is already sometimes not the easiest task, but it adds to the reluctance for them to seek care with their doctors. So helping to normalize the grief associated with losing erections is very helpful to really sort of aid the recovery process, if you will. Now, I also acknowledge there's barriers in healthcare. Whether that's because between the doctor and the patient, maybe the provider is uneasy about talking about it. Maybe they're not warm and welcoming. Maybe it's because they don't have all of the information, or they're not comfortable with this topic because it's not really taught in medical schools in great detail. So you have a lot of providers out there, outside of urologists and sexual health experts, who just may not have the expertise to be able to counsel you. So making sure you do, you're forthcoming with your doctor, and even if they don't feel comfortable, getting them to refer you on to somebody else, I think would be beneficial. And another issue with healthcare is that we often talk about sexual health counselors, but often access can be limited, particularly outside of main metropolitan centers. So, sexual counselors can be limited. Mental health counselors are somebody who, could also play a role just because of the depression and anxiety rates that are pretty prevalent in patients who are diagnosed with cancer, but access can be limited. And then I think that as it pertains to bladder cancer, there's very unique barriers. Some studies say that having a stoma, having an ileoconduit, about 50 to 75% of these patients who came into surgery sexually active don't resume sexual activity after surgery. Whether it's because they're avoiding intimacy because of concerns of leakage or dislodgement of the stoma. Maybe there's odors, maybe there unique sounds that are made by having a stoma. All of these things factor into an individual's sort of self view of themselves, and also in terms of how attractive they may feel, and essentially impairing their confidence with sexual activity. Having surgery versus radiation, those are very different treatments. They have different considerations. End of life care. Some cases of bladder cancer, we know bladder cancer is a very serious diagnosis, and in some patients, unfortunately, they will pass away with their disease. But that doesn't mean towards the end of life that things like sexual health need to necessarily be forgotten. Like, people towards the end of their life care about this too, and having this conversation is really important to have with patients. And then another one to mention is even sexual orientation, like, gay, bisexual, queer men, etc. They experience very unique challenges. I mean, if you think, just as one particular example, I mean, it's been reported that after having prostatectomy or cystectomy, that they can lose their anal receptive sexual pleasure, or even from radiation. That can all change. Also, because of erectile dysfunction, it may preclude anal sex, because that requires the penis to be more rigid than it would be for vaginal intercourse. And on top of that, for patients in heterosexual relationships, as men get older, maybe they have some erectile dysfunction, but not uncommonly, their partners may not be as interested in sex either. Whether that's because they're postmenopausal, et cetera, it happens. Whereas if you're in sort of a same-sex relationship, that partner, the other male, is still, has a regular sex drive. It doesn't necessarily wean. So there may be a higher risk of misalignment of sexual expectations, let's say. So in terms of causes of erectile dysfunction, generally we try to group them into two main categories. There's definitely overlap. There's sort of the physiologic, that's where there's vascular problems, neurologic problems, anatomic, maybe endocrinological, so meaning like low testosterone as an example. Iatrogenic falls under there. But psychogenic ED is hugely important. And there's different elements of that, whether it's decreased arousal, maybe decreased intimacy, maybe there's partner issues, psychological stressors. It's important to acknowledge that, because for patients who have bladder cancer, like there's a lot of concerns and fears that would be normal to have. I mean, at the top of the priority list are probably concerns about disease recurrence, but of course, altered body image concerns, maybe urinary control, maybe incontinence happens after surgery, and not just because of cystectomy, even TURBTs. And with all of this, there can be depression and anxiety and impaired intimacy. So it all sort of compounds one another. In fact, we know that having a diagnosis of cancer is linked to higher rates of depression. But you may not know that if you have a cancer diagnosis plus you have sexual dysfunction, you have 2 times the risk of depression compared to the average person. So psychologic issues such as depression and anxiety are very important to try to tease out. And part of this is because there is inherently a self-perpetuating cycle. And we deal with this all the time. How do we break the cycle? If you take an average guy who might have some erectile dysfunction, he's got some erectile dysfunction. Now in his mind, he may say, oh, I'm not satisfying my partner, I'm blaming myself, all these negative thoughts, etc. Now when they go to have, sexual activity, now they're not performing as well because they're anxious about their ability to perform, or will they perform at all. Eventually over time, that builds up and you stop being interested in sex. So libido meaning sex drive. So sex drive starts to go down, and then you start avoiding sex, which just makes the erectile dysfunction worse. So there is a definite self-perpetuating cycle that we often see, and it's really a matter of trying to break that cycle. So I mentioned erectile dysfunction is common. So who's at risk? Basically everybody. I mean, as we get older, medical issues happen, not specific to bladder cancer. So those can obviously contribute. But as it pertains to bladder cancer, having a bladder tumor resection, maybe intravesical therapies, for sure radical cystectomy and radiation, but maybe you're also the partner of somebody who's going through bladder cancer. And now because you see them being stressed with their diagnosis and having regular cystoscopy, and you see what they go through, or chemotherapy, now maybe you feel guilty for wanting to have sex. And so, even partners of patients dealing with bladder cancer are at risk as well. In terms of, how these different treatments impact erections, it's varied. Like, for example, the TURBT, in its most straightforward sense, it in itself should not cause erectile dysfunction because we're kind of away from the nerves. But you have a TURBT because either you have a new diagnosis of tumor, or you have a recurrence of tumor, or maybe you've been peeing blood, whatever it may be, it's a major stressor. And so after TURBT, it has been shown to just impact sexual function negatively, resulting in anxiety and depression. But that may be more around just the initial diagnosis and the initial treatment, because data has also shown that for patients in one study where they had their BCG, for example, around the time of the induction BCG and the original TURBT, they had some ED. But as time went on and they had their maintenance therapy and did well with no recurrences, that sexual function sort of improved. So most of the time, if you're having some ED after TURBT, it's thought to most likely be related to more psychological issues and perhaps emotional burden. Cystectomy, on the other hand, that's different. Like, that's a pretty major pelvic operation. There's the iatrogenic causes from just the major operation, but again, changes in how the body looks, changes in how the body functions, changes in how the body eliminates waste. There's emotional and psychological changes. There's complications after cystectomy. There's readmission rates after cystectomy. All of that can take a toll, not just on an individual, but on relationships as well. Sometimes when we try to look at sort of more the physiological reasons for erectile dysfunction, one of the things that's been studied is arterial insufficiency. So if we can't get enough blood flow to the penis, that can cause ED. Now, that's actually more commonly found with things like high blood pressure and smoking history and diabetes, et cetera, because the blood vessels basically start to get at least some degree of atherosclerotic disease, which means that the blood flow that wants to kind of go through a nice artery is limited. Also, if you've had radiation or trauma, that can impact the inflow of blood. Neuropraxia is more likely to be the culprit as it pertains to radical cystectomy and pelvic surgeries and why it causes ED. And this is because anything that affects nerves, whether it's the brain or spinal cord or peripheral nerves, which are the ones that can be affected with surgery, all of these can impact the blood flow because of nerve-related changes, and can cause this erectile dysfunction. And again, some series, 70 to 100% of patients who undergo these types of surgery get erectile dysfunction. A venous leak is another cause. It's not really super relevant in this case, but basically these are situations where when the corporal bodies are supposed to fill up with blood and put pressure on the outflow, they just can't put the pressure on. So if there's a venous leak, that can cause it too. And then another thing to even bring up, and very, very understudied, is penile shortening. So penile shortening is actually very common after prostate removal, after bladder removal, after pelvic surgery, similar to nerve related issues. When the nerves are affected, it can affect the tone of the penis, and it naturally will just shrink. One study said over 55% of patients had some element of penile shortening, and the average length reduction was around an inch, which to some patients is going to be a big change. And I'll talk about that a little bit more in terms of options and treatments. In terms of, I put here chemoradiotherapy, but really it's radiotherapy. When radiation is given to the pelvis, it also causes erectile dysfunction. In the prostate cancer literature, where radiation is also utilized in the pelvis, the rates of erectile dysfunction are slightly better than with surgery, but radiation itself has other side effects as well. And, it also causes erectile dysfunction. It just may not impair it as much as surgery would. And then I mentioned this again too, but after going through a radical cystectomy, like just having a diagnosis of cancer is stressful. I put here a picture of a roller coaster ride because it can be a roller coaster ride. You get a diagnosis, or maybe you have TURBT and your tumor's taken care of, and your surveillance cystoscopy is clear. But then maybe one day there's a recurrence, and you go through this, periods of where you're really happy with things and you're doing really well, and maybe a few setbacks, and that takes its toll. It often results in a reprioritization of where sexual health falls in your life. If somebody is going through the ups and downs of a cancer diagnosis, they may not want to have sex, and that impairs intimacy. And I talked about partner support. That's for patients who have a partner. For patients who don't have a partner, who are single and looking, the stress can be even higher, because how do you disclose your history to your partner? Of course you want to, but inherently there's some element of just being a little insecure because of all of the above. So I talked a little bit now about what dysfunction looks like and kind of why it happens, but now we'll talk a little bit of how we make it better. So how do we get your sexual function back? So penile rehab or penile rehabilitation is sort of our way of discussing and coming up with treatments that can hopefully help you to regain your erectile function, your sexual health, etc. And there's different elements to it. I mean, and there's more to it than this, but essentially the idea is to optimize you going into surgery and start rehab as soon as possible right after surgery, so that you can use lower doses of medications and maybe come off of medications and maybe try to preserve your penile length, try to preserve the natural smooth muscle and endothelial functions of the penis by promoting earlier blood flow. That's kind of what penile rehab is supposed to be striving towards. What penile rehabilitation is not is that it's not going to make your erections better than they were before surgery. Like, we are really, the goal of penile rehab is to try to preserve as much preoperative function as possible. So I think this was actually a good slide to summarize what the options are and how we sort of view penile rehab. I mean, the first step, it comes back to that grieving of sexual health and erectile function, is we want to acknowledge that there's an issue, and then, talk to your doctors. There are medications that can be used, Viagra, Cialis, etc. There are procedures that can be used, intracavernosal injections, intraurethral suppositories. If those fail, you can have surgery, penile implants. And while doing all of this, counseling by yourself, with a partner, is critical. So I'll just talk kind of about each of those individual parts, and then hopefully we'll have some time at the end for some questions. But starting with pills like PDE5 inhibitors. So this would be, again, the classic blue pill. Your Viagra, Cialis, or sildenafil, tadalafil, vardenafil. Those are the generic names. The purpose of the medications is to improve blood flow to the penis. There have been studies that have shown that by taking a low dose of tadalafil, like 5 milligrams a day, can significantly improve the erectile function that you have, but drug assisted, meaning that if somebody who used daily tadalafil versus somebody who didn't, they would be more likely to respond to a higher dose of tadalafil when they want to actually have sex versus somebody who just went cold turkey and took a larger dose of tadalafil. So earlier use is recommended. There can be also different combinations. So we can also use PDE5 inhibitors with some of the other treatments as well. But PDE5 inhibitors in particular is kind of one of the early things that can be done. There are many barriers to using it, though. Like, a lot of patients who start on them, they don't work, they stop using them. They don't want to try again. They don't want to alter the dose. They just give up. And I think that that's important to acknowledge, because if you're falling into that category, having a discussion with your doctor about why it didn't work and maybe what are some of the other options is worthwhile. These medications, as common as they are, they do have side effects. So every medication that has side effects is prone to people stopping them because of those side effects. They're also not cheap. I mean, they do cost money. They're not always covered, and it may not be always convenient. To have to take a pill before you want to have sex loses some element of spontaneity as well. Another option could be transurethral suppositories. So Muse is kind of one of the more common ones. It involves the placement of a pellet that dissolves in the urethra, and by dissolving in that location, it's actually going to cause vasodilation. It's going to promote blood flow going to the penis, resulting in the erection. But the side effects of the medication is that it can be pretty uncomfortable. There can be pain and burning associated with it. So it's not one that we use terribly often, but it is certainly an option. Intracavernosal injections are fairly commonly used. These medications, and this is where that the diagram of the anatomy at the beginning was sort of useful to review, because again, you don't want it to go on the top of the penis. You want to go at like an angle on the side to go into the corporal body. And this medication is self-administered. It's a very tiny needle. You sort of clean the penis. You draw up the medication in the syringe, and you inject the medication into the penis. And you start low and you go slow. So when you're first starting with this medication, you would start at a very low dose, just a few units you would administer to yourself, check for a response. If that didn't work to the amount that you wanted it to, then the next time you can go up by 5-10 units or so, depending on the medication and the dosing. But the point is, you have the ability to self-titrate your own dose. It's kind of like having one of those beds where you have your own number. You can find the dose that works for you for the result that you're looking for. The downsides to the medication, of course, it's a needle. I tell patients that 10 out of 10 men, when we talk about ICI, they say there's no way in hell I'm going to have a needle going in my penis. But honestly, 9 out of 10 men who do it they're actually very happy with it, and it works well for them. But the risk would be hematoma formation, so bleeding, scar tissue. If you keep injecting into the same spot, that can result in scar tissue. And with the penis that normally wants to stretch to give you an erection, if one side has scar tissue and it's not as stretchy anymore, then that's going to result in curvature. And then the other risk, of course, is maybe the medication works too well. And if you have an erection that it hasn't gone down after a few hours, then you have to come into the emergency department. That risk is actually relatively low when patients after pelvic surgery use it, but it is a risk of intracavernosal injections. There are other devices. There are suction devices that can be used to, you pump this suction pump to basically pull in blood flow to the penis to allow it to become rigid. So that sometimes can be used. We don't use that too often, but it is, one option. Penile length. This is another thing that I had mentioned before, but there are devices on the market that exist to try to preserve the amount of penile length that one has. So there's actually just a randomized controlled study published recently for this device that looked at patients after prostate removal, and patients who started using this device kind of right away, like within a month of surgery, ended up preserving about 1.7 centimeters relative to those who didn't. And with this device, you essentially, it's a soft clamp that will pull the penis out on stretch, and you wear it for 30 minutes, a few times a day. Doesn't fit nicely under pants, so you have to sort of be in the comfort of your own home. But this is definitely one option to try to regain some of that penile length. And it's most often recommended in the early postoperative period as opposed to years later. But it is used for post-prostatectomy penile shortening as well. And then, getting towards the tail end here, when it comes to if everything else fails, what else can you do? So there are penile prosthetics that can be used. Most commonly, there's an inflatable penile prosthetic, but a malleable one exists as well. The inflatable, and I have a video that I'm hoping will work, but with an inflatable penile prosthetic, these yellow lines here, these yellow cylinders, are placed into the penis to replace those corporal bodies that normally would have filled up with blood, but don't fill up anymore. And there's a reservoir, there's a pump that's placed in the scrotum, so it's all concealed. And when you want to have an erection, you pump it up, the water goes from the reservoir into the cylinders, and you get an erection. When you're done, you press a button and it decompresses. So a lot more moving parts than the malleable. The malleable is a little bit more straightforward, but the downside is it's kind of like it's just a bendable sort of material. So when you want to have sex, you just bend your penis up and you're good to go. But when you don't want to have sex and you have to sort of bend it down, it's never really fully limp, if you will. And so that is not always ideal for patients. So I'm going to see if I can, if this video will work. Let's see. Alex, if you don't see something, maybe you just let me know, but it looks like it's working on my end. Except it's
Yeah, it
making
seems to
me,
be.
oh.
What
Are
I'm
you able to
seeing,
still see the video?
yeah,
Are you seeing,
what I'm seeing is it says this animation is intended to provide a basic understanding of how the implant functions. But that's
okay,
all I'm seeing.
that's all you're saying. Okay, thank you. Yeah, it's bringing me to YouTube, so I don't think it's going to work.
Hmm.
Yeah, no, that's too bad. Okay, that's okay. But essentially, it was just an animation highlighting how the oh, I wonder, no, that won't work. Just how the prosthetic works in terms of inflating and showing you how it becomes rigid and then decompresses. So that's really what the video was. Oh, maybe here it'll work.
Hmm.
Does that work? Can you see
Yep.
that? Oh,
Yes.
perfect. There you go. There you go. So this is again just showing that inflatable penile prosthetic. You pump this pump that is located within the scrotum. This results in the fluid from the reservoir, which is sort of in the pelvis, goes into the cylinders, which give you the erection, and then when you're done, you just decompress it, and it goes down. So that would be an IPP, or inflatable penile prosthetic. So just to sort of summarize, I think that it was a pretty rapid review. Hopefully, uh, based on what we talked about today, you can sort of appreciate that to regain your sexual function, it requires not just an evaluation of your physiologic function, but also some psychological adjustments, maybe psychological assessments, evaluating the relationship, seeking help from other counselors. Because really, at the end of the day, when it comes to bladder cancer, this is a really good example, because bladder cancer is often a multidisciplinary disease to deal with. You may see a urologist, a family doctor, a medical oncologist, a radiation doctor. That's multidisciplinary care. But as it pertains to your sexual function, I think just keep in mind that sexual function also needs multidisciplinary care. And your urologist is one member of that team, but seeing a sex therapist, they can address what the loss of sexual function means to you, how to aid in sexual recovery. Seeing a mental health specialist if you're stressed, if you have depression, physiotherapist, maybe your concern is incontinence, and the incontinence is dissuading you from wanting to be sexually active. So seeing a pelvic floor physiotherapist, talking to your pharmacist about optimizing the dose and the timing of erectile aids, not giving up on something like Viagra or Cialis after just one try. And then I know, Alex, in the beginning, you talked about support groups. I mean, Bladder Cancer Canada has been phenomenal for having support groups locally. And I think it's important to have these, even as it pertains to sexual side effects and erectile dysfunction, because you want to be able to have shared experiences and talk to a group who might share similar emotions with you as well. And I think my last slide here really just comes back to one of my earlier slides where I mentioned that masculinity does not equal erectile function. A lot of what we're talking about here is really how do we regain that erectile function? But you can still have sexual satisfaction beyond erectile function. Other ways, you can find other ways to be intimate with your partner. That could be hugging, kissing, cuddling, finding other ways to gratify your partner. New methods, new experiences to bring to the bedroom. Maybe adjusting to a new way of life with your partner. Maybe sexual health isn't as much of a priority anymore for both of you, and maybe that's okay, but you just assumed it wanted to be a priority for your partner when really they said it's okay. And having that open discussion with your partner is so important to make sure that that you're supported, but that you're also on the same page about this. And this is where the sexual health counselors can be really, really important. So I think that's my last slide. I'd be happy to answer any questions, but thank you everybody for your attention and for listening today.
Thank you so much, Dr. Nayak. I'm sure this material will truly help our community after their treatments. Especially, the one slide that I found interesting was the one with I think it was the thickest rectangle, and it had all the different types, like, penile dysfunction, erection, the psychological aspect and so on. But just understanding it, and as you know, being men, we tend not to talk about this as much. As I think women have an advantage over us. They will talk about stuff like this, but we tend not to. And I bring this up because in one of the support groups that I facilitated, one of the caregivers, the wife of the patient, actually brought up sexual function. And us guys on the call we were caught off guard. We didn't know how to react to that. But it was interesting. She had no problems bringing it up. So anyhow, so thank you again for the presentation. Wonderful.
You're welcome.
Thank you. So now we're going to open the floor to questions. Please type your questions into the chat function. But in the meantime, I do have a canned question here that I would like to ask. And that is, how long should a patient wait before resuming sexual activity after the surgery?
Yeah, that is a good question, and we're talking radical cystectomy specifically, or for bladder tumor resection?
Either.
Either, yeah. I mean, for transurethral resection of the bladder tumor, you can get back to sexual activity much faster than a radical cystectomy, because the radical cystectomy is such a major operation that you're often kind of winded and probably don't have much interest in sex for almost 3 months. You're just trying to get over that big hurdle. But usually we advise at least taking a couple months to just recover and focus on the recovery for radical cystectomy. Usually around 3 months, at the 3 month mark is when I start to discuss erectile dysfunction and penile rehabilitation. But for TURBTs, that's more, as soon as you're feeling up to it, as long as you're not having bleeding and you're feeling okay and there's no pain with urination and you're up for it, you can start that anytime.
Okay, thank you for that. There's a question here in the chat. The question is, how and what are you mentioning possibility of erectile dysfunction and its resolution when you talk to your patient who is a candidate for RC?
Great question. So, that it's a little bit tough. So definitely in the preoperative counseling about a patient who's considering radical cystectomy, when we're talking about the potential risks and complications of that surgery, we will discuss erectile dysfunction. And that would be generally when it comes up. The tricky part then is, in terms of resolution of erectile dysfunction, sometimes that never happens. 80 to 100% of patients after radical cystectomy can end up with erectile dysfunction. And I would say that that is something that we see more often than not. The erections are going to take a hit after radical cystectomy. There may not be recovery naturally. But just because there's no natural recovery doesn't mean that we can't do something. There is always something to do. And we saw all those different options, medications, injections, even all the way to a prosthetic. So sometimes it just depends on how motivated an individual is to regain that element of their life. But to answer the question, preoperatively is when it's discussed, and we do discuss what their erection quality is like in the postoperative period. But I try to be very realistic, and I don't say that there's going to be X percentage of recovery for erectile dysfunction postoperatively, because I think that gives a little bit of a false sense of hope. I do give some numbers when I'm just doing a radical prostatectomy. So we do that for prostate cancer, of course, not for bladder cancer, because there we can do a little bit more nerve sparing. But yeah, so we would just have the discussion postoperatively if they did have ED.
Okay, great, thank you. Next question says, at the start you mentioned something about getting prostate cancer once you've had bladder cancer. Is that accurate?
Not that you get prostate cancer once you've had bladder cancer, but in patients where the bladder and prostate are removed, like a radical cystoprostatectomy, there's been some data that shows that in that prostate part of the specimen, if they look at it, up to 40% of patients could have some prostate cancer that it was just incidentally detected, that it wasn't known about going into surgery. There's actually Canadian data on that as well. So, that's what I was getting at, is that prostate cancer is a very, very common problem among aging men. It doesn't mean all prostate cancer is bad. There's very indolent disease that you probably don't even need to know about. But yeah, about 40% of men who have a radical cystoprostatectomy might have some prostate cancer that happen to be caught also.
Interesting. Next question. I've had regular cysto, unfortunately going through a divorce at the same time. I then was celibate for some time and then subsequently experienced erectile dysfunction, regularly. Is that to be expected?
The question is it to be expected to have some erectile dysfunction? Given that sort of history, I do not think the cystoscopy is necessarily going to be the element that's contributing to that scenario. I think in that situation, there may be more, whether that's, psychological or some anxiety about sexual performance, et cetera. Like, I think it might be more useful to see a sexual health counselor in that scenario. I wouldn't say it's to be expected, but it sounds like there have been some pretty serious stressors in your life. So I don't blame you for having that.
Okay. Next question is, you mentioned the ejaculatory duct and it showed it was outside the prostate. Can you ejaculate after you've had RC and had your prostate removed?
So no, you can't ejaculate anymore. Essentially, that whole system is removed. So the seminal vesicles, which was sort of on that picture, I didn't highlight it too much, but the seminal vesicles attached to the prostate, those come out with the whole specimen. And on top of that, you basically have a pretty aggressive internal vasectomy at the time of radical cystectomy. So ejaculation in its truest sense is not possible. There are some people who may, especially if you have a neobladder, if you do ejaculate and you have that contraction of your pelvic muscles, there may be some fluid that comes out, but it's not true ejaculatory fluid. I mean, it could be everything from urine to even some of the glands in the urethra. It could be that sort of fluid, but not ejaculate.
Okay. Next one is if you are having regular bladder scopes, and have had several TURB procedures, should a person be doing more to ensure a healthy prostate, or would abnormalities be detected during the mentioned procedures?
Very, very good question. Very good question. So that probably comes down more to philosophy, and I hate to say it, because a lot of times as specialists, we receive referrals from other doctors for an issue. This person has blood in the urine. We do a cystoscopy. They have bladder cancer. We manage the bladder cancer. But we don't necessarily manage the other things. Like we're not managing blood pressure, so on and so forth, because that's where their family doctors come in. And through a similar token, it could be argued that having your prostate checked is a normal part of a physical exam with your family doctor. So really, they should be doing that on a regular basis for you. And so it's not an automatic assumption that your urologist who's doing bladder tumor resections and managing bladder cancer, it's not an automatic assumption that they're monitoring your prostate at the same time, because that really should be the family doctor. At the same time, we're all a little bit different. So in general, like if I see somebody for the first time for a cystoscopy that I've never met before, and it's a male in the age range where I worry about prostate cancer, I do tend to get a PSA and I do a finger check of the prostate, like a rectal exam. But there's no guidelines on it. We're sort of all products of our own past experiences, and I've actually caught pretty aggressive prostate cancer once before by doing that, and it just reinforced the importance of it for me. But I don't think everyone does that.
That's interesting. It just prompted a question in my mind, and that is that, given your experience, should that be something that is taught in med school?
Yeah, for sure. So it should, and it is. And, we do, I'm part of the academic faculty here, so I'm part of the urology undergraduate curriculum, and we do lectures on prostate cancer, bladder cancer, sexual health. But every school is different. Every school has its own curriculum. I do think that there's value in it. We even once published a study on, there was a time when rotating on urology was a mandatory rotation for students, whereas it can be optional in most situations. And we surveyed the students who did the mandatory rotation for a year, and then we surveyed the students who had the optional. And lo and behold, the ones who mandatorily rotated on urology had more comfort with managing ED, managing blood in the urine, managing prostate cancer, because they had a little bit more awareness. Unfortunately, it doesn't always work out that way, that we can get our way. So we proved there was a benefit, but they then switched back to making it an optional rotation. So every school is different.
Yeah, thank you for that. I'm just doing a time check. We've got about 3 minutes left on this call. So we could probably squeeze in one more question. And I do have a question in mind. So let me squeeze mine in and we'll open it
Sure.
up and see if anyone else has one. So given that the nerve endings are at the tip, at the head of the penis, is that ever impacted when you have a procedure? So for example, when you have the bladder removed, uh, does the nerve endings at the tip of the penis ever get impacted and cause, issues with stimulation and so on?
Great question. So generally not actually, because a lot of the nerves that give you that sort of sensation, those are actually not affected the same way as the nerves that are allowing for the dilation of the blood vessels. Like those are the sensation ones are actually okay. So that's why some people who have erectile dysfunction and can't get an erection can actually still feel enjoyment from manipulation of the penis in a lot of situations.
Excellent. Thank you for that. Okay, one more question, the last one. Is it better to discuss all this prior to RC surgery or after the fact?
Prior, 100%. And, extrapolating from prostate cancer literature and even my own practice, in patients who aren't informed fully about their treatment decisions, those are going to be the ones who have more treatment regret. And decision regret is definitely something that's real, especially for things like prostate cancer and bladder cancer, where as a patient, you have options. Your doctor says, this is, the diagnosis, your options are A, B, and C. And then they kind of throw it back at you and you have to make the decision. So the
Mm,
only way that you can make that decision is if you're educated and empowered with the information that matters to you. Erectile dysfunction might be important to one person and is a non-factor for another person. So having that information, having that discussion before surgery is critical to make sure you choose the choice that's best for you.
great. Thank you for that. Okay, so I think we're going to close now. Thank you again, Dr. Nayak, for the great presentation. As you can see, there are a lot of thank yous in the chat, so wonderful job.
Thank you
Uh,
very much.
Thank you. So, in closing, we hope you enjoyed this session. In November, we will be hosting the counterpart to this session, focusing on women's sexual health after bladder cancer treatment, hosted by Dr. Andrea Kokorovic. I hope I pronounced that correctly. In December, Dr. Black will host a session on clinical trials. In the chat, Teresa has shared a link to register for those events, as well as a link to a quick feedback survey, which will also come through email. We would love to hear your thoughts on this session and suggestions for future presentations, so please take a few minutes to complete the survey. If you would like accommodations to complete the survey, or you have any additional comments or questions, please call us at 1-866-674-8889 or email info@bladdercancercanada.org. Thank you again to Dr. Jade Nayak for sharing this important information with us, and thanks to all of you for attending. Have a wonderful evening.